Dustin? All right, so let's start the next case. Dustin is joining me. All right, so this is a case of a 39-year-old lady who'd been previously diagnosed with an achalasia type 1, I think in 2019. She actually was treated for that once. Actually, there's a significant stasis here. Interestingly, with the rigid flex 35, but not a very high filling or pressure volume back then, probably 5 psi. So we are not sure what the actual diameter then was. But she did better. She's all still doing better than prior to her first treatment, again, which was 5 years ago. And then she got a little bit lost to follow up, but she was doing okay. And again, she was pregnant and had obviously other issues. This is so hard and large that I may not get it through. Type 1 seems very possible, right? I mean, it looks rather dilated. Also looks a little bit siphonoid here at the lower end. Trying to take this with me to the stomach.
What sort of pressures do you use, or would you have used when you're using pneumatic dilators?
Well, I mean, the Rigiflex, if you use it, then it's standardized for the diameter only at its maximum inflation pressure, and that is by the company 20 psi. So if you use less, which you I guess can do, then you simply don't know what your diameter is. Probably if it's 12, then you already also have, a rather large effect. But I'm not aware that anyone really has looked at that. And again, the specifications of the company say 20 psi. And as you all know, there's different regimes to do this. Some people do it very quickly, 15 seconds. Some people do a minute. Some people do 2 minutes. So it's a little bit all over the place, which is also one of the problems why the data sometimes don't look as good in comparison to others, because the heterogeneity of how it's actually performed is too large. Okay, it's really dilated. I don't know what this is. Okay, so maybe talking about her symptoms. Again, she was treated before. She currently has an Eckhart of 4, which is daily dysphagia for pasta, but it's only for pasta. She has not lost weight, so 0 points there. She has no chest pain, which is often in type 1, so no pain. And she does have regurgitation from time to time. I gave her 1 point on that, so this would be an Eckhart score of 4. Good. Okay, I'll try to suck this out a little bit and get this out. It's going to interfere a little bit with the flip, maybe not too much. I don't know what you think, Dustin. I would still go ahead with it.
Yeah, I think with a small amount of food, it's always nice to clear that. I know one thing that we've worked on is most of our symptomatic achalasia patients, definitely when they're untreated, even when they are treated, we try to have all of them be on a liquid diet for at least 2 days beforehand. Then I don't know if you have a kind of a pre-op instructions for your achalasia or suspected achalasia patients that you use.
So you can see a little bit of me trying to do something there. Apart from that, she may have tendency towards hernia when she's treated, but none thus far. A little bit of the food remnants are now in the stomach. Clean that out real quick as well. And then we have a look at the pylorus. I guess for her we're going to focus on the esophagus. So she does have a hook stomach, have to go almost in inversion to get to the pylorus, and here everything sorry, this is the filter, looks fine. Yeah, there's the papilla to the left, all good. Okay, taking out the remaining CO2. This is some of what I cleared into the stomach, and now let's go back. Z line is at around 42, 43, which I don't know if I find this quite often that in achalasia type 1 the esophagus is a little bit longer on average.
There's always that question if you're a straight shot or not.
Very good, absolutely. That's one, and I mean obviously if it dilates to the sides, why shouldn't it also dilate a little bit in length, right? Mm-hmm. But you're right, I mean straight shot versus not. So try to get this as clean as possible, also to avoid any lodging with the catheters once they are filled into the pharynx and then into the bronchial system. So this looks pretty good now.
Strong work.
All right, now we can get started, huh? Gel, please.
Justin, can you talk to us about dry catheter?
Yeah, sure. So the dry catheter artifact is actually when the balloon gets completely occluded, and that makes the diameter measurements in the other sensors actually become faultily elevated. Yeah, you typically see that with very strong contractions, though sometimes you can almost see like a reverse dry catheter artifact from the LES in patients with untreated achalasia. So, yeah, so I don't know we'll see it on this one, but if I do, I'll certainly point it out.
And what's your management of it?
Just to really to not include it in your interpretation. Yeah, I think the biggest consequence is if you look at it and you can be falsely convinced sometimes that maybe your EGJ or even your esophageal body is open. So it really is just that you have to recognize it and then kind of not incorporate it into your interpretation.
Do you deflate and then inflate?
No, usually if you're just kind of continuing the protocol, the stepwise filling will often get to a point where you're no longer occluding the bag, and then you can get valid measurements.
So this esophagus is so wide that the flip doesn't naturally pass through. So I'm still not, now I'm across the EGJ. Obviously this may also happen during manometry, right? That doesn't advance into the stomach. But now this looks fine. And I'm leaving the scene.
All right, so yeah, so we started filling once we were across the EGJ. And certainly as we're filling now, you can definitely appreciate that waste that's at the EGJ. All right, looking good. So yeah, so we'll go up to the 50 ml fill here. Yeah, so even here, this is one of those scenarios sometimes where even there appears to be some of these diameter changes in the body. I don't think that's actually contractility. You can also see how it just is inversely related with the respirations. Sometimes it is just that fluid kind of sloshing back and forth in the bag. One of the things we've kind of talked about some of the, maybe the lack of fidelity when the bag is partially filled here. I think it's a little bit of what we're seeing at this point. Yeah, and looking at the EGJ here, kind of making the measurements between crural contractions. Obviously, you can see that there's not much of a hernia. We're in between the diameter, or in between the crural contractions, but also here the pressure is very low. So these measurements aren't going to be all that meaningful. So we'll go ahead and increase up to the 60 ml fill now. All right, then at this point now, you can hear these measurements between the crural contractions. So the EGJ is about 11 millimeters. DI here is actually at 7, but this is very much related to this low pressure here. So yeah, again, here, technically we're over 15. You could maybe apply this DI here, but the much more meaningful value here is really the diameter. And so yeah, so at 12 millimeters at the EGJ, definitely in a a not normal kind of a borderline reduced component at that point.
It's interesting what's up here, huh? It's something 1, 2, 3, 4 centimeters above what is probably what is the EGJ and the hiators.
Yeah.
So we'll have a look at that later through the scope if there is any sort of
Yeah.
little ring
Yeah,
or
no,
if
I
it's
think
kinking.
yeah,
or
all
whatever
that
it
all
is.
that is there. I think it's it's actually that little sigmoidization that you saw in
Exactly.
the esophagus. I think that's
Little kinking, yeah.
yeah, it's just the way that the bag is kind of
Yeah.
being pushed. Yeah, exactly. So that's one of those things that I think just because the flip is straight and the esophagus is not straight, we're seeing a little anatomic imprint there.
So that will go away when you.
In all likelihood.
We'll see, and we can double check later. That's our working thesis for now.
Yeah, so we'll go up to 70 ml fill here.
Something about the filter on and off.
That's right. I mean, we can play with it, right? Let's take the filter off, maybe.
Sure. So even here, yeah, even at this point now, pressure is getting up to 30, and yet our diameter here is getting to be, 13, almost to 14. And it actually kind of fits with her clinical story. I mean, her dilated esophagus, I mean, it's probably never generating, over 20 millimeters of mercury. And so, if she really, ate a lot of food and generates a little bit of a column, she probably is emptying. Dry, starchy foods, though,
So we should
it's
write
probably
down.
more the
So
dilatation that's the
14.1,
main issue.
5.6 and 28.
Yeah.
So we're going to put these values down, right? I mean, we would have a diameter of 14.1, the sensibility of 5.6, right? So she's treated clearly, I mean, and balloon pressure of 28. And as you said, probably simply the esophagus is too dilated to have a significant downforce. And that's the cause of her symptoms. Now again, obviously, if we would open this up all the way, she would very likely have reflux, right? I mean,
So what was the values now?
14.
14.
now they're even a little bit higher, 15 and around 7.
Yeah.
But I mean, we can already say it's not a diameter of 7 or 8 or 9,
Yeah.
so it's pre-treated.
So you've taken the weighted average.
This is the weighted average right now, but yeah, if I can take that off, and it'll be pretty similar probably in this. Yeah, we talked about earlier, I generally like the filter off. I think, I just see some things a little bit crisper and still kind of focus on the maximum changes, but I saw other cases the change is not dramatic. Yeah, but even here now without that, the diameter is getting up to about 15 millimeters at the EGJ, and yeah, and pressure here is in the mid-20s, but it gives a DI of 6.8.
And the colour changes here that are not there, what's happening
The color changes.
on the flip one?
Simply a representation.
Yeah, it's just a slightly different color scale. Yeah, I generally ignore this part and focus just up here.
Okay, let's maybe scope real quick and have a look how that looks from above.
Sure.
Try to hold it. Daniela, can you hold this, please?
Yeah,
Thank
but I
you.
think the real, the clinical implication here is, when we look at these EGJ parameters here, you definitely would question what type of gain you would maybe get from doing additional EGJ targeted therapy. Whereas instead, I think, even the, obvious retention that she has, as we proved with the start of our endoscopy here, is probably much more related to kind of failure of the esophageal body. And
So what would you do with her, Dustin? Would you do anything?
yeah, I think it really comes down to a little bit of her degree of misery. And yeah, if it really is something that, daily dysphagia is really bothering her, and if she was truly having an issue with solids, I mean, there's still a little room here. This is a diameter of 15, 16. I may offer her additional therapy, but yet I think that with that, these parameters here, that the chance of gain is going to be, probably not as.
What about the possibility of making it worse if she's got an atonic esophagus and, how much the stage could actually be worse at the end of the day after you?
Oh, exactly. Yeah, no, I think it's definitely a.
wrap. You should be able to deal with the wrap also if that's what you're doing.
Yeah, well, I wouldn't do a wrap here, but yeah, I think the question would be if, and that's definitely where some shared decision making would come into play here to kind of sort out, how, with dietary modification can get her to a point of high quality of life, and if her, if her daily dysphagia from pasta is really, really bothering her. I mean, this seems like a place where there's some great pasta. I'm hoping to eat some tonight. So if that was the case, then I think you have that shared decision making and take it on here. But at least with this flip findings, you can kind of let her know that the chance for gain here may be a little bit lower. And so, your potential kind of risk to benefit ratio could be a bit lower. Yeah, but I think, if she was really, really miserable, I would offer her potentially a poem. And
I thought that too.
mhm.
I mean,
I would read out at first, I guess, right? I mean, she had a 35, probably, right? 35, but with not full potential. The risk of her perforating, I would do another 35, but more aggressive. The risk of her perforating, just based on the literature, is super low because she was pre-dilated.
Okay.
And if she does better with that, fine, we're done. or she can come back in 5 years. I mean, that's also up to the patient, I guess. I mean, I don't
Oh,
personally.
same, yeah.
I mean, we don't use anesthesia, right? We put them in, zack, propofol, we do it. It's a quick thing. It's easy. It's safe. So I guess you could go down that route and just screen her, do a barium afterwards to know where you're standing, like half a year later or so. You could obviously offer a poem, but she does have reduced symptom load, right? And she already responded quite well to the first dilation. So I guess there's, as you said, shared decision making, different routes. I personally would redilate with a 35 and see how she does.
Yeah, and I would include that among her options for sure. And if she,
Yeah.
appreciated her previous response, if she had a good response there.
So what?
Why do you think perforation rate is extremely low with the second dilatation?
The data show that. The dilation is, the perforation usually occur on the primary dilation.
Okay.
So all subsequent dilations are safer than the first one.
Do you regularly do multiple dilatation after the first one, maybe after 2 months, the second one, or you wait and see and how respond the patients?
Yeah, it depends. I think every patient that I do a pneumatic dilation on, especially if I start at 30, I definitely have that, that potential that they're going to get another one early on. And it's very individualized. It depends on how the patient's doing, their degree of symptoms, their quality of life, kind of their preference for undergoing another procedure. And sometimes that's 3 months later they do a 35. Sometimes it's 2 years later that we may do another dilation.
So there's a number of protocols, right? Also in the literature. I personally like to do a barium swallow around 3 to 4 weeks after the procedure and call the patient to see if the Eckert score has significantly come down. I can remove this now.
Yeah.
And if the patient is fine and the column has significantly decreased, I'm good for the moment. And if not, then I offer additional again. So I wait around 3 weeks, 4 weeks. And there's quicker protocols, but that's also obviously sometimes based on availability, on how insurance thinks. I think this why there's such a large variation among countries. But I mean, I think we have time. It's a chronic disease. We can look at the symptom evolution and then we can react. That's my take.
Yeah, definitely. Yeah, there's never a rush to do these things, or very, very rarely. And so,
unless you're completely dysphagic, different story.
Yep.
But this is clearly not the case here.
Yep, exactly.
About quality of dysphagia, I'm always amazed how it's different. I have patients and they have a decompensated achalasia. It was forgotten 20 years ago, and the whole esophagus is wide, large, and they say, I'm fine.
There's also data on that, right? I mean, the type 1, the burnt out, they get symptoms very late, but then you are late, and then you have to, then it's almost pre-esophagectomy, right? Versus the type 2 or type 3 who are much earlier symptomatic, and you have if you find them earlier, well, I believe in treating them, right? Also based on that.
Yeah, and I think that's always, I think I've come a couple of dictums in achalasia. One is you can't make an asymptomatic patient feel better. But the only scenario that I am a little bit more aggressive is if somebody that you can actually show progressive dilatation and remodeling. And when I see that, I'm definitely a little more aggressive. And often if you go back and talk to those patients, they're not doing as well as they think. It's having to sleep in recliners, and their diet is nothing but soup and things like that. So but it's always, there's never one factor. It's never one measure. It's never one event. It's always, a multitude of factors. And then, really shared decision making with a lot of the patients. Really trying to accept, and sort out their degree of quality of life, and even their acceptance of risk. And most risks with achalasia treatments are very, very low. But of course, there's nothing that's 100% safe either. So, always kind of weighing out options and coming to a decision together.
You end up re-looking before you said you were going to re-look above.
Oh,
We did.
Nothing there.
There was not really nothing there. No.
yeah, I think that was purely
Sorry.
just that bend in the.
I looked,
That was the bend in the esophagus, and it was just the wall.
and you
kind
could
of
see it
pressed-
disappear on the last measurement on the 70. It was visible on the 60, but not on the 70. But sometimes you have these esophagi where there is a muscle segment which is still more active than others, especially after POEM, for example, because I mean, it's never that you really cut it very evenly. I mean, it's an electric knife, right? And there's differences, and then you sometimes see these indentations, and patients may be symptomatic to that. And then, but then you can also dilate it as a first measure before you consider repoem or something else.